I don't want to talk too much about the success stories, but I want to talk about the big delusion, these issues that are coming up every day with the performance of AI systems in the real world, because people say of data bias, because of potential harm, failing patients, and then some ideas on how we can tackle these, overcome these. If at some point AI will way that is feasible, accepted, and quite, you're interested in some more description of the and papers, especially these ones, also inference and counterpart machine question about healthcare that somehow summarizes many of the topics of this talk. So very quickly, we probably you are familiar with that, but the usage of AI comes very important for achieving the objectives that these objectives have been already introduced in 2015 of precision medicine and precision public health. And the first one is more about the individual, and the second one is about the populations. And sometimes achieving one does not necessarily mean achieving the other one. Precision medicine is basically an approach for disease treatment and prevention. So it's making predictions and actions before something happens. So preventing the happening of diseases or when the disease happens. Deciding on treatments. But this approach does not take into account a single domain, but looks at multiple dimensions, in this case, genes, environment, lifestyle, and it's personalized. So everything revolves around a person. When you talk about early risk prediction, when you talk about differential diagnosis, so understand what this is going on, and when you talk about treatment optimization, so when it's too late to prevent the disease, but you have to take actions. Precision public health, you can get from the figure, is not anymore about a person, but is about a population. When you talk about population, it's kind of tricky because you have to decide what is here the observational unit, the target unit. Is it geographic area? Is it a demographic strata? And so on. And there are other things that concur into this collection of information domains, such as ecological data, information about other species, diseases, pathogenic diseases, and collection of information about ecological exposures, and so on. Now, if you optimize the health of a single individual, it does not necessarily mean that you're optimizing the health for populations, because you have different distributions of the population, different priorities. You might spend a lot of resources in reducing the risk of acquiring a vector-borne disease, which would be very good for Florida, but wouldn't make sense in Canada. Yes, they don't have mosquitoes. So priorities change and so on. And you can think from an engineering standpoint about this such like Pareto optimization, where you have to, multiple objectives that sometimes are clashing, and so you need compromises. And in order to achieve both objectives, and many of these objectives, now we kind of have the ability to shop for many different types of data. You have electronic health record data, which is one of the most prominent sources of biomedical data that is available also publicly from the hospitals. You have genotyping of humans and pathogens. You have information about laboratory biomarkers. You have information about drug prescription. And you can link these data with pivoting. For instance, if you know the residence of people, you can link their zip code to ecological data measurements. If they are wearing wearables, you can collect ambient sensor data and link it to them. If they give consent to extract information from their social media data, you can get a lot of behavioral and structural information. So we have all this multimodal data integration, individual at community levels. So precision medicine for the individual and precision health for populations. You have more data, more linkage, but also it's easier to triangulate. So there is a higher chance of privacy breakage, higher chance of harm intended or unintended with data leakages or malicious utilizations. Often these things are publicly shared, but they're not necessarily up for grabs. So the challenge is in preparing ourselves to study these data increase as well. Nonetheless, let's assume we have an ideal case and we are doing things in an ethical and responsible way. We have had and we are seeing a lot of success stories by using multimodal AI for prediction of, say, protein structures, and with the advent of deep learning, the DeepMind's AlphaFold basically beat all the competitors and destroyed 15 years of research in 1 year. Another one is breast cancer screening, the analysis of images. The Karen's Maya is a NHS approved tool that uses convolutional deep learning to and provides better diagnostic accuracy than human readers. This has been validated in clinical studies. And we're not even talking about large language models. And in fact, the initial work on, let's talk about electronic health records, so the data that comes from the hospital, the one that we are mostly exposed to, and they're easy to work with, especially if your university has a university hospital or a research data warehouse. The early deep learning models were developed at first on tabular electronic health records, but then with the advent of transformers, they started utilizing even more information sources, especially the clinical notes, those tremendous amount of text that are available in the medical charts, but are never used in regular machine learning. And so the pre-trained models, the GPT, started becoming more and more prominent, and now we know that ChatGPT passed basically all school bar exams, medical, law, business, and so on. At University of Florida, we developed the Gatortron GPT, which is the largest language model for medical purposes. It's not the largest in terms of parameters, but it's the largest in terms of data used for training. And in fact, probably you have seen millions of times these graphs about the growth of generic large language model. I have augmented these with some data points that are relative to specific biomedical large language models, because you can see that when you try to specialize a large language model, oftentimes you end up with a very similar number of parameters, but just these are fine-tuned versions. But there isn't much said about data that has been used. And so to make an example here, Gatortron GPT, which is not the largest one, is, I will show that, is the one that still holds the highest performance because of the goodness of the data that has been trained on. An interesting thing, I will not talk about this today, but biological large language models, so those models that are not trained on human text, but are trained on genomic text, DNA, RNA, and proteins. They're still below average in terms of parameters and data sizes, and so this is kind of a field that has been a bit falling behind. But parameter size is not the sole driving force anymore, and this is quite important. I'll make a point later. One clarification, biomedical large language models are different, also architecturally, when compared to classical large language model. And they have the same core, so they can use the same architecture that you can see in Llama, GPT, whatever state space model you want to use, etc. And most at the beginning, they were simply fine-tuned on a special subset of literature, for instance, PubMed articles or medical books. But now the current state-of-the-art models are multimodal. So they can process text, but they can also process structured data through an architectural modification. And so the important thing is that they can use electronic health records, which are high-dimensional, longitudinal sets of diagnostics, procedural codes, labs, vitals, medications, a lot of numbers that you have to either vectorize or transform into text with different strategies. So you need some important architectural design here. It is important because not only you're working with a type of structured data that is uncommon, but also because when you're looking at the old school notes, the way in which they're written and stored and processed, they have a lot of language deviations. There is a lot of clinical jargon, and sometimes they are almost as structured as a billing chart. And then there is also imaging data. You probably have seen that, for instance, certain large language models are incorporating image analysis and they do diagnosis, but they're still not very well integrated in most models, and they have not been validated with clinical trials. That's quite important. Biological LLM, again, they have other issues. They have to handle much longer text, for instance, because if you think about the genome, it's not that you have words, you have basically a bunch of genes that are very, very long. So there are a lot of challenges. Now, let's say, again, we are able to create these new architectural improvements over the basic LLM designs. And so moving toward, we have a good foundational base for learning good models and say that we have enough computational resources. What do we train and fine-tune this model on? Well, the first one is let's use large healthcare databases. As I said, electronic health record, you can find a lot of these repositories for free. The medical information mart for intensive care, or MIMIC, is one of the most famous free EHR databases out there. It has quite a sizable sample. There are over 500,000 encounters from 365,000 patients with everything that you usually see at the doctor's visit. So there are diagnoses, procedures, medications, vitals, lab tests, and so on. It has the clinical notes, which is for about half of the patients. It has radiology reports, and it also has imaging and other type of data like ECG data and other data that comes from like ultrasound. So the majority of medical large language models use Mimic because it's free, and because it's also used as kind of a benchmark in terms of compute needed, performance with respect to the say medical Q&As and so on. But Mimic, it's actually a very small database. It only includes emergency room admissions and only for one medical center in Boston, even though it's more than 10 years. So you can imagine how small it is. So there are larger health databases. And in the United States, the federal government had funded in the past 15 years the patient-centered outcome research institutes, clinical data research networks, CORE-NET. And across about 15 years, they created 8 or 9 consortia. One was discontinued, that came back again, but let's say about 8 or 9 that cover across all US. They're highly representative of healthcare data, of research expertise and patients. And they use the same common data model, which means that the data are exchangeable through a set standard. The databases respond to the same structure. University of Florida is part of One Florida Plus, which is the Southeastern Consortium that has more than 65% of Floridian healthcare providers. And then you get Alabama, Georgia, California. I don't know why California, southeastern US, but we have California, Arkansas. And over 1,000 practice or clinics. It's not 21 million anymore, it's 24 million people. Over 1 million encounters, and there are about, now it's 5 billion data items. This is a nation, this is not national, this is southeastern US. And One Florida itself, only One Florida is 60 times the size of neighbor. So, I know it's not as large as the internet that ChatGPT has been trained on, but you can imagine that this is something that OpenAI has never seen. So what can we do with a large language model if you have been trained on this huge set of data? What are our use cases? These are some of the many. You can use it for administrative tasks like billing, refining the clinical notes after visit summaries. Sometimes, I don't know if you had experienced that, you go back home, you look at the after visit summary and you say, what is this? Like sentences written by the doctor, the nurse very quickly. So it could improve medical literacy somehow. It can be conversational when you send messages to the healthcare provider. Either they answer, if you have an emergency, go to the ER, otherwise take an appointment, which isn't really a great answer. You might want some medical advice very quickly and so on, so conversational. Augmentative, this is about getting more information for a patient without burdening them. There is a mandate now in certain states where when you go to the doctor, the nurse should ask you something about your social circumstances. If you feel safe at home, if you are experiencing economic distresses, and so on. Well, these questions are sensitive. They take, not only they take time, but they're sensitive. The people might not feel very comfortable answering them. But sometimes they could instead bring them up during a conversation. So that's one way in which this the AI model can be used. But instead, for research and clinical or prospective studies, there are other very, very important, and I'm going to cover this now, applications. One is study recruitment. If you're a researcher, you want to do a clinical trial, sometimes it's very difficult to find eligible people and time-consuming, and even screening them for pre-existing conditions or other requirements for the trial can be problematic. So large language model can scan these large database. Can you imagine scanning 24 million people in a secure way and identify those that could be the best fit for a new clinical trial? Right? Diagnostic and prognostic. Again, can we improve our ability to predict the risk of a certain disease or predict multiple outcomes from current disease status? And then finally, it's interventional. So, which is different from predicting. Like I can predict the probability of death of a person that gets sepsis at the hospital, given their background conditions. But this is very different from saying, oh, if I change this treatment, then the person is going to increase or decrease the probability, because treatment changes are something that is very biased in the data. The doctors follow guidelines. So most of the time, the doctors are not going to flip treatments randomly. They're going to, so when you predict, you can simply predict the course of events according to the standard of care. When you ask the AI to say, what can I do in order to change the probability of death, the AI has to change variables. So sometimes they could change variables in a completely meaningless way. So interventional instead must be known meaningless. And let's see how the diagnostics work. So just prediction with large language models without having further problems of making interventions. Gatorton GPT was developed at the University of Florida with NVIDIA. We were lucky because one of the alumni made a huge donation, about $25 million a few years ago. We have over 100 NVIDIA 800 nodes with about 1,200 800 GPUs each, so in total. And then they are installing as we speak the newest Blackwell, another, I think, 10 or 20 million investment that should be deployed in a few months. So Gatorton GPT first started as a BERT, only 9 billion parameters. Then in 2023, so 2 years ago, it's already older, we used the GPT-3 architecture up to 20 billion parameters. And it was trained only on 10% of one Florida data. So only the data from University of Florida. But the amount, only clinical notes, not even structured data. So the amount was over 600 gigabytes of data, 82 billion words. And even without, even only using 10% of that database and only the clinical nodes, it's still consistently ranked at the best medical large language model. Even better than the largest ones. Even better than those that have, I don't know if there is MadCom here, the one has 500 billion parameters, but consistently in most of the benchmarks from diagnosis to clinical trial reports to even inferring social determinants of health. So this tells us the story that the data may really, really make the difference. And here I want to give the 3 examples of how you can use the system for clinical trial screening, diagnostics, and prognostics. So the first one is automated clinical trial eligibility. As I said, we have low recruitment yield due to intensive human efforts for screening, because you have to actually identify the patients through the clinics, to chart review, if they had given consent previously to be contacted. It really, really requires a lot of work. But just to answer the simple question, can we identify people with a certain disease who might be able to enroll in a clinical trial? Say we want to test a new treatment. But these people might need to have a certain age range, be free from certain comorbidities. They might not be under other types of medications. They might be able to come every week, and so they need to be closer to the sites and so on. We were able to use Gatorton GPT to basically scan and create prompts and queries that would mimic a questionnaire that would be administered to a potential clinical trial candidate by looking at the notes. So for instance, okay, let's say that the criteria is a person that is between 18 and 39 years old, diagnosis of diabetes, only taken these 3 brands of insulin, no other comorbidities, no glaucoma, and living at least 10 miles from these certain facilities. So you create these prompts. You have, you can actually feed the prompt to the LLM. You can get an answer back. You have some kind of forth and back, and you end up with a set of people, potential candidates. Then you see how they consented to be contacted, and at that point, you can move on to the recruitment phase. So you're saving the whole amount of manual work. Performance are really good. They work for some diseases. They work better or less. You can see there was a trial done on Alzheimer's cohort and another one on cancer cohort. These are not real clinical trials. These are emulations on trial that had been done afterwards. So basically, you have the ground truth because you know if those people had been elected to be participants of the trial or not. And we have longitudinal history. To be fair, it's not been done only at University of Florida. There is a new competitor. The paper just came out in Nature Communication last year. It's called Trial GPT. Want to see how it differs from the Gatortron one. The idea is the same. Another one is about diagnosis here. And we could, many of these things, especially for diagnosis and prediction, outcome prediction, when they were done in the old way, you would basically collect a lot of tabular data, feed regression models, scoring models, machine learning models, and then get predictions for the individuals. Here, everything is pre-trained. You have to do a bit of fine-tuning at the end. You can do whatever you want to kind of contextualize the answers of the LLM, but I would say it's little work compared to all the effort that was made before to create data sets. Here, you basically need data sets only to validate and to do some initial fine-tuning or RAG or whatever you want. So let's talk about, before was identification, now it's diagnosis, okay? Let's set a research question. Can we detect if a patient that is coming to the clinic is experiencing discrimination because of their illness or social circumstances, so where they're living, and almost as good as if they were compiling and filling up a psychometric question. This is as the example, actual example, we want to document stigma in people that are living with HIV. Stigma has a high prevalence in the population. It can be internalized, it can be externalized, and there are actually psychometric questionnaires. One is called the stigma scale. They're time consuming. Sometimes they're not always accepted. People don't feel comfortable filling them up. There is a paper trail, and so on. However, it's been noted that instead, when they are doing counseling or when they are talking more privately with a healthcare provider, these things can come up, and they can provide a similar amount of information in their own words rather than reading the questions heavy to answer every single question. So the idea was, can the clinical notes that are coming out of these patient-provider conversations be used to identify the important dimensions of stigma in the form that is similar to a standardized question. And we had to do some work because we had to create a questionnaire. We had to transform the questionnaire into natural language concepts, and then we had to create keywords for which we were first selecting purposely selecting the clinical nodes. So there was some fine-tuning, some work to do, but then eventually was a way to basically ask a question to the pre-trained model. So the way in which we do that is that we ask the large language model to complete or give us an answer based on the nodes that have been extracted that are relevant, because you might have 1,000 different clinical nodes and they are not relevant to the context, so you have to narrow that. We have an upcoming presentation at the American Medical Informatics Association meeting in March, presenting this work, which is still undergoing, but the interesting thing is that we're not able to get all the dimensions of the questionnaire. The first results we got is that we are very, very good in detecting when stigma is happening, and if some basic dimensions like internalized stigma, externalized stigmas, and other sources, those can be well detected. But when you go very deep into, like, the questionnaire has about like 11 questions in the small form and 42 questions in the long form. So you can imagine that it's a very difficult task for a large language model, especially because these are clinical notes that have been generated post hoc. So this was not a prospective study. This is an observational study. And then the next is, so we did identification, cohort identification. We spoke about kind of diagnosis of stigma. And here is prediction of outcomes. As if you see, I have not talked about interventions at all. So what about predictions? Let's ask ourselves a question. Can we predict if a patient with a bacterial infection is going to respond to the antibiotic treatment given their current clinical status? We're not changing the antibiotic treatment. We're just following clinical guidelines. Okay. And it's actually important research question. It's public health priority in the US, especially because antibiotic resistance is one of the leading causes of death for bacterial infections in the US and worldwide. Florida, we were able to collect over 140,000 hospital encounters and about 64,000 patients only in Florida. So it's a large data set. Would be very large for machine learning, right? Because we are able to link all those data elements that we've seen before, from social determinants of health to prior medical histories, lab tests, vitals, demographics, everything. And so we can actually use this data set to do a regular machine learning model on tabular data from these electronic health records. But then the same data could be used to simply validate the large language model, Gatortron, because Gatortron is pre-trained. So we can ask the same question by prompting the information on the patient. The issue is that you can't prompt an electronic medical record chart because you have billing codes, you have lab values, and so on. So we use a procedure that is called the subword feature method that basically translates structured data into unstructured data into sentences. And so it would, for instance, for all the billing codes and all the diagnostic codes and the lab values, it would say the patient presents on this time of the day and the week with these symptoms, with these high blood pressure, because in the electronic health record there was blood pressure of 159. Then we write sentences. And then there is the final prompt, which is the question, like, what is the probability of death during the hospital stay, or of a readmission within 30 days, or a positive, or an antibiotic susceptibility test, which is positive, resistant to the antibiotic that was given. So these are the questions that you can ask. You can do all the training and testing, cross-validation, whatever using machine learning. Then you can set a test set aside as usual. That test set you can fit directly into the large language model without any pre-training. That's what we did, apart from generating this prompt. And the thing was that the Gatortron outperformed the traditional machine learning in all but one performance. The F1 score for some reason, but around the ROC curve, which is discriminatory ability, sensitivity, and precision. Precision is very important because you have a prevalence in the population of medicine, rather than sensitivity, which is like dimension. It doesn't. So the fact that you have a higher or lower prevalence in a population, the sensitivity doesn't capture that, but instead with the precision, you have that. So you know that it would work better in that context or not. So it is interesting because we didn't even do any fine tuning, any additional, learning, zero shot, one shot, nothing. It was the regular system, which, I mean, could put all of us out of job, but this demonstrates that it has a tremendous capabilities for prediction. And now, okay. Now I will curb your enthusiasm. As we're talking about the Big Depression, you can read in the headlines that AI can fail to generalize, can fail to specialize, can amplify bias. And there is this thing that bigger AI models, even if you put more data, may not perform better. I have a bit of reservations at the last sentence, but I think it's the way in which if you have more data is always better, but you have to be able to kind of handle them in a slightly different way than usual. And this is true not only for regular machine learning, tabular-based machine learning, but also for large language models. These are examples of 3 recently published papers that for large language models show that in the real world, they do not do that. They do not have a good diagnostic accuracy like in the benchmarks. There were at least 2 studies with large number of patients. One was over 2,000 patients. The other one has a large number of physicians. They had consensus on over 50 physicians. And then the last one, which is important, they are biased. There are different types of biases that were analyzed here, cultural bias. The problem is that bias is also not only something that is sociocultural, but can be also medical bias in the sense that, for instance, when there is a bacterial infection, doctors might need to be biased by prescribing a stronger antibiotic because they don't have time to get an antibiotic susceptibility test, and they are afraid to make a mistake. Instead of giving an antibiotic of a prior generation that is widely available, and this would improve stewardship and might have the same effect with less side effect for patients. So that is a kind of a bias that exists, and it's present, and it actually can harm the outcomes of an infection. So how can we kind of formalize these bias and the issues with health data? More data, as I said, so the health data can contain bias of all sorts, and more data does not solve the problem because you have the same amount of bias. 2 simple examples are like, smoking and nicotine-stained teeth. They both predict lung cancer. People that smoke are likely to have nicotine-stained teeth, and if you use them in a prediction model, you can use either value. This is a toy example. Another less less simple is if you use paracetamol, Tylenol. It is often associated with asthma because it's used to treat early respiratory symptoms, especially in kids when they are not feeling unwell. And then sometimes these symptoms exacerbate, and then the parents end up bringing the child into the ER because they tried with an NyQuil, they tried with a Tylenol, and it didn't work. And if you think of the Tylenol, the NyQuil has Tylenol and also some anti-allergy medications sometimes, so that might have a short effect, and then the asthma gets exacerbated. So these could lead to thinking, and you would have a ton of data about it. This will lead to think that if you actually stop paracetamol, you would stop an asthma exacerbation. But instead, it's just in the temporal chain, so you would simply probably go earlier to the ER because the child doesn't get, this kind of um, mild symptom containment within the first few hours. So this is because we are observing data and we are making predictions of observed data, and then we are making hypothetical counterfactual predictions. So think how things could be if I took paracetamol away. So we don't have those data because most of the times the paracetamol has been given first. However, there is a solution that is 200 years old. It's a clinical trial. It's a randomized study where you pick, where you give a don't give randomly paracetamol to a population, and some of them are going to benefit, some of them are not. And by randomizing, the population is more or less uniform. So you're kind of breaking down all these possible bias. The problem is that can be done only in selected. Often the population is small. You might have a little bit of bias that too, because it could be only say one demographic population, one demographic strata, and so on. Sometimes they're not feasible for ethical reasons. I mean, think about the effect of smoking on cancer. Would you force someone randomly to smoke or not smoke for 20 years, right? So there are things that you cannot do. And the medical databases, even the large one, they contain very little limited data from clinical trials. However, randomized data is still there, even though in lower percentages, because sometimes doctors deviate from the guidelines. Sometimes you have multiple options for treatments. Sometimes people don't follow the doctor's recommendations and don't take the drugs. Sometimes there are medical errors. So there is this kind of randomization lurking. You just need to make sure that you are able to exploit that to find the new knowledge. And so if we exploit these, we are able to move from prediction, because you can always predict with biased data. Nothing wrong with that. You're going to be very accurate. To intervention. And this technically means moving from having let's call about a large language model, a system that is a world model, because it has a knowledge of the world. And from a medical standpoint, is like moving from diagnosis, just responding to the question. It's an associational question. If the person has a symptom, what's the disease? The prognosis is, okay, the symptoms are here, can I predict the future, but I'm not changing anything. And then the prescription / intervention this is the real world model. In epidemiology, it's called counterfactual prediction, as what if an alternative treatment is sought? And in order to do that, you need somehow to re-emulate randomization, or you need to have your data, more data, whatever you want, respond in this randomization to the best of your instruments. You can do it 2 ways, 3 ways, different ways, but one is, for instance, using extant knowledge. So you know that certain associations are spurious because they have been tested previously. So you can tell the model, these are spurious associations, don't use them. And the other one is that instead you could actually discover new causal structures. There are algorithms that give you well-founded hypotheses on novel causal mechanisms that break down the bias. And these are called, these graphs that you see, these are directed acyclic graphs. They are like Bayesian networks. You can actually calculate the effect of a certain treatment with respect to an outcome by doing the so-called due calculus, and will remove the bias and will tell you when to add or exclude a variable from it. Sometimes you know those structures because you have extant medical knowledge. Sometimes you don't know them, you can try to learn them. And you can even rebalance your data by doing a so-called propensity matching. So you can rebalance your large data and before feeding it to training to emulate randomization. And that's how basically causality is embedded in AI to create interventional AI models. The difference with traditional causal inference is that in causal inference, you have to predict the causal structure predeterminate. You need to know those, you need to draw those networks by yourself. You cannot use an algorithm to infer them. Most of the times, these are linear models, very few variables. You cannot handle many time points because their formulas are, they have combinatorial exposure. So if you calculate the first time point, the third time point, the fourth time point, you need to have a number of data that is to the power of. So it's important that this has been what's done so far for a long time, but it's clearly difficult to handle, especially when you are doing precision medicine, when your set of covariates and it's large, and also you have multiple time points. Causal AI, that's how we name it, is a relatively new community. There is a lot of work in discovering the causal structures, in using high-dimensional spaces and reducing them, for its clustering, autoencoders, anything that you like. You can think about all the nonlinear interactions that you want, and you can have dynamic models like even use LSTMs or whatever for dynamic interventions where you change the treatment over time without incurring in the problem of combinatorial explosion. It's not a magic wand because it's still bound to causal assumptions. If you feed the causal AI system with an existing causal network which is wrong, your results are going to be wrong. If you discover a new causal network which is wrong, your results are going to be wrong. It might be even wronger than just feeding raw data. You can do more or less the same, I think almost over time, with large language models. This is not my work. I'm working on a model like this, but I haven't published it yet, so I was beaten. But this is quite an interesting work. And ask counterfactual questions to the large language model. No one forbids you to ask those questions right now. You can go and ask GPT-4 or O1 a counterfactual question. But it's going to answer in its own way. And we don't know if the new O1 or O3 have actual causal reasoning embedded. They say they have causal chain of thought, they have reasoning. We don't know if that is causal. Causal chain of thought instead is an explicit approach to reasoning that incorporates those causal knowledge networks that I have previously shown. The typical application example is like this. Let's make an example for diabetes. Metformin is a sugar-lowering drug that is used to treat diabetes. It seems that it's also lowering the risk of glaucoma. However, glaucoma is a common condition associated with diabetes. So, this brings up the bias as before. It could be that everyone takes that because they're more likely to develop it. So will metformin work against glaucoma, or is it just a spurious association? This is actually an interventional question. And this work and the work that I'm doing with my colleagues, basically we're testing standard LLMs, generic LLMs, medical LLMs, and then the causal reasoning LLMs. So basically ChatGPT, Gator-Tron, O1, and then the causal reasoning on top of all of them. How does it work? Basically, you create an additional prompt with causal knowledge that has been learned from your rebalanced data that will tell you some causal constraints that can or cannot be. And so you say, okay, this is the question, will metformin work against glaucoma, given the questions above? But then you say, oh, we found in our data that there are these, this is causing this is causing this, and so please use this additional piece of information. It's a little bit more complicated with that because we actually have treatment effects are calculated, but you can think that is a way to inject an additional set of constraints to your prompt. And those constraints have causal directions, so they will help. The study that was published showed that there is an improvement over most of this was not done against a reasoning model, but it seems that it is a promising approach. Someone asked me before, is the O1 or O3 reasoning mode able to incorporate causal reasoning? My answer is always, I have no idea. That's what I'm working on my next paper, the benchmarking. So this might be, again, some wasted work, but it was work. The last slide, I have to go very quick here, is that sometimes there is the practicality of interventional AI anyway. Because when you make predictions, you just predict the future, whatever. But when you make interventions, one thing is that not all causal variables are actionable. Sometimes if you want to use a new drug on a patient, then the patient's insurance is not allowing that. That's not actionable at all. Also, the interventions must be feasible and acceptable, and they can be implemented in the community if the intervention proposed by the AI asks the patient to move to a different clinic that is, I don't know, 50 miles away. That might not be acceptable. Not all of them are responsible or fair, again. There could be things that are not evaluated in all the process, even if you try to incorporate social determinants of health and so on. This could exacerbate disparity, so this could basically improve precision medicine performance in precision medicine objectives, but decrease those in the precision public health. So eventually, the involvement of the community and stakeholders, policymakers, we work a lot with the Florida Department of Health. We have focus groups. We come up always with a list of things that could be done, and they say, oh, if you're asking the AI in the prompt, please ask, if we can use these interventions, because those are the one that seems mostly feasible, acceptable, and fair. I conclude here. There are some references for anyone who is interested, papers of mine and of colleagues. And thank you for today.
Questions for Dr. Prosperi? Have you done any characterization of the database that you have of all the implementers, like how much variation of certain diagnoses of like one condition, different types of billing codes, natural language, and like how much there is that type of like charting that can cost?
Yes. Yes, we do. So you're right. When you have something that is billed, it's very different from a true diagnosis. So the way we have done until now, but things could change in the future, is to create so-called computable phenotypes that are a set of rules that look at the billing codes, lab tests, procedures, and they try to find multiple combinations of these codes such that the sensitivity and specificity of identifying a condition is very high. For instance, for HIV, if you look for an HIV test, and even if it's positive, sometimes that is not assuring that the person has HIV. Everyone can get an HIV test, and sometimes the result is not even showing. Just because they got it doesn't mean they're positive. Some people take the anti-HIV drugs. They could be pregnant, or they could be taking the pre-exposure prophylaxis or post-exposure prophylaxis if they had an unprotected encounter, and that doesn't mean they have HIV. So we create all these type of measurements and combinations of codes and so on to make sure that we have, when we identify a condition, there is high sensitivity and specificity. It's not 100%, but it's usually very high. Fortunately, that is a manual algorithm. And then we have, when we do that, we create the rules, we extract the data, and then we have doctors, medical doctors, nurses, we pull up, I don't know, 100, 200 random patients with the clinical charts, and they validate, and they tell yes, no, yes, no. So that's how we know the performance. Now with the large language model, you might be able to ask the question, can you identify people with HIV from the electronic health record? I have to get a bit updated on this new way to do things, because somehow picking this new way of doing things cannot be immediate. Our algorithms are validated. We have a platform when we access the electronic health record system where you can load the computable phenotype, because it's standardized, and I can transfer that computable phenotype to another of the partners of the PCORI consortium, so they can run the analysis on the same definition in their hospital system. With a large language model, I honestly, maybe it could become much easier, because it takes about, I mean, the one on HIV took us 1.5 years to complete. I'm doing one on delirium now. There is going to be another one on chronic pain, but every time you have to come up with a new algorithm of the cycle. If a large language model can do these accurately in 5 minutes, well, okay, but the validation is going to take time, and the deployment in the community is also going to take time.
With regards to your HIV stigma, are you looking at other the intersection of populations that, like, for example, Black people and queer people, which are higher populations of HIV, like they've received stigma potentially already. So how are you, like, comparing that versus, like, what stigma the person might already be getting?
So that is part of the questionnaire. There are questions, especially the longer instrument, the one that has 40 questions, that incorporates stigma that is related to HIV and stigma that is related, not necessarily related to HIV. Our population has a high percentage of Black African American and Hispanic, just because Florida, and the people living with HIV. It's a prospective cohort, and everyone has been surveyed with a questionnaire. So what we did was to ask the patients a consent if we could look at their notes and see if they had mentioned that, if we were able to match and their conversations with some of the items, the stigma questionnaire. So yes, we detect stigma in general, and then we can say if the stigma is associated to the condition, if the stigma is externalized, like coming from external sources because of the condition or not. Instead, it can be also internalized because they are ashamed of themselves, basically, because of the condition, even though they might not perceive it that externally. So there are a lot of different dimensions. The questionnaires that have been administered, they have these dimensions, and now the Berger stigma scale is more focused on HIV, but then there are other instruments that not only focus on the condition. The problem is that, as I mentioned, the large language model can't answer questions at that fine-grained level. So we have a very, very good ground truth and a diverse population, but the data that has been linked from the electronic medical record is limited, again, because people might not feel comfortable to talk about that unless they have a very good relationship with the provider. And it's complex. So these are tasks which, we might conclude that even a very well fine-tuned large language model might not be able to capture all these nuances yet, just because you don't have all those nuances in the data.
Do you have like a control population?
Yes, we have sampled people that did not have HIV, and we were checking if there was stigma. So we have nodes that we use for as negative controls. In that case, if you can still pick stigma, but HIV-related stigma you should not pick that. So we're going to have some false positive rates that can be calculated as well. Yes. Well, that's a matter of a probability. So there is always someone that doesn't develop a condition. I made that as a toy example, but you could say, for eating, I don't know, being exposed to asbestos, or you give that as an outcome probability. So you say in 10 years, your risk is 30%. So, or 60%, 70%. So there's going to be out of 1,000 people, 700 will develop it on average, and 300 will not. If you obviously you want to be as precise as you can with a person, because a person could have, they could smoke a certain brand, they could smoke or breathe, like tell you, oh, I inhale everything, or I don't know. So you might have a better way to calculate the probability, but it's always a probability. It could become higher or lower, but there are so-called unobserved confounders for which you will never be able to calculate an individual effect. We call about conditional average treatment effects and individualized treatment effects, which means that you have a vector, a set of variables that are representing your individual. There can be 1,000 variables. There can be 10,000 variables. But if two individuals have the same variables, they are two different people. They might even have the same probability. One of them could develop it and the other one could not. So you're going to give a very precise value, but it's still something that will happen with a certain probability. So that's where can never truly predict an event with 100% probability, but you can personalize the probability. So your probability could be X%, another person probability could be Y%. All the people that are the same values in that vector will have the probability that either like you or another person. There is, and there is not a good answer to that. We had a lot of focus groups because these questionnaires change every few years. So they are revised by revising the questions in a way that is more culturally adapted to a new generation. So I can say, yes, it's accounted for in the questionnaires. Does Gatortron or ChatGPT speaks more Gen X or Boomer or Gen Z? I don't know. But for that, I have no answer. And the same for, yes, the demographic slang. Make sure to sign in using the UofL on the tables.
Before we leave, we'd like to thank you so much for coming. And this is little bit souvenir.
Oh,
Thank you for your time. We saw you
Yeah,
two on.
can you
that.
take a picture with you?
Yes.
How about set up food up here, come along and gather as group?
Yeah. Thank you so much for coming. We'll join you now for the lunch.
I was like,
Yes, I am. How are you? All right. Nice to meet you.
We are probably 2/3.